Okay. So we were here, right? Okay, we were discussing here. So I shared about this one. The to assess the fetal well-being, ultrasound is as a primary tool for the assessment, not appropriate, right? They have mentioned in where the essay health guideline, right? So here uterine palpation for tone and tenderness, soft, tense, tender, or non-tender, assess the tightness of contractions are present, assess the placental side using the ultrasound, point of care, and formal depending on the woman's condition and assessment. So you can assess the placental side by using the ultrasound, right? So keep this point in your mind. Okay, then once placenta previa has been excluded, you can do the speculum examination. Otherwise, it's a contraindicated, right? It's a contraindicated. Okay, then they have clearly given a proper one for the placenta abruption. Okay, so here the placenta abruption occurs. There are partial or total detachment of the placenta prior to the birth of the baby. It's usually sudden event that is OBS emergency, chronic pathological vascular process to contribute the most cases of abruption. The placenta abruption is the most often reevaluate the but can conceal. So risk factors: previous abruption, preeclampsia, fetal growth restriction, on vertex presentations, polyhydramniosis, advanced maternal age, multiparity, low BMI, pregnancy following assisted reproduction, right, intrauterine infection, premature rupture of membrane, right, from and the abdominal trauma, smoking, drug use, maternal thrombophilia. These are the risk factors. Keep these points in your mind because they are given these scenarios in a proper step. Okay, the clinical features: continuous abdominal pain, back pain. This is a painful vaginal bleeding, right? And the tense woody feel of abdominal palpation. So tense woody feeling, the tense woody feeling, remember this is a key point, so called Covale uterus, right? So fetal heart rate abnormalities, blood loss can be vary between mild to life-threatening. Vaginal bleeding is often dark and non-clotting, signals of fetal compromise or uterine irritability, contractions more than 5 in 10 minutes, right? So then the clinical features, continuous, the same thing. The diagnosis. The diagnosis, many women present with the placenta abruption established labor. Diagnosis is more often made clinical presentation and assessment. The ultrasound may be helpful if there is a large retroplacental hematoma. However, absence of ultrasound evidence of retroplacental clot does not exclude the diagnosis. Performing ultrasound to assess the abruption should not delay the clinical management in unstable patient, right? In mild cases, diagnosis may be made until after the birth when a retroplacental clot is identified on the placenta examination. In severe cases, women may be present with a significant shock and consider concealed abruption if abnormal or back pain is present, right? So management here, I have to follow that the management flow chart that we all discussed, right? And here the conservative management. The conservative management may be appropriate in case of a small abruption, very preterm gestation with no maternal or fetal compromise. Administration of maternal corticosteroid, right? Why we are administer corticosteroid? What happened? Again, they are given 2 hours past me. Can you see again? They're asking me to. You can see my screen, right? They're asking me again to start the previous session. I don't know what is wrong with this Zoom. Right? Yeah. So conservative in a small abruption. Okay, very preterm gestation. So we are giving corticosteroid from 23 week of gestation. Why? To measure the lungs, right? To lung maturation of the baby, right? Very important. Keep this point in, keep this point in your mind. Neonatology consultation, observation for further bleeding. Maternal hemoglobin is managed. Monitor for IUGR, maternal and fetal monitoring. And discussion with the woman will determine the appropriate placenta management. Like in the future, you can discuss how to deal with the baby, the labor, and everything. And the other consideration of a labor is precipitous, like in multiparous women, consider urine drug toxicity screening, like those things, other consideration. So we'll do this question to you to get an idea, okay? To you to get an idea, then we will go back to our case. 39 new old woman, gravida for para 3. Present to the emergency department 36-week gestation with the 2-hour history of bright red vaginal bleeding and the constant low abdominal pain. She has a similar but small episode of painless vaginal bleeding 2 days ago that resolved spontaneously. Her 3 previous pregnancies resulted in uncomplicated vaginal deliveries. His mic is on mute. Okay. Then her antenatal care has been otherwise uncomplicated through the low-lying posterior placenta was noted on her 20-week morphology ultrasound. Here, then follow-up by biometry at 34 weeks showed the placenta age to be 22 millimeter from the internal os. She does not take irregular medication aside from the pregnancy supplement. Now tell me, this placenta previa is okay or problematic? Now tell me from this given information. What do you think? In this given information, placenta is okay or not? I will explain after. Okay, yes. Okay, then on examination, the appears distressed and pale. Her pulse rate is 130, BP 80/60, respiratory rate is 22, SpO2 96. Then the temperature 36.8. The uterus is firm and tender on the palpation with increased tone between contractions. A speculum examination revealed 2 to 3 centimeter dilated cervix with the blood pooling into the posterior fornix with no cervical lesion visible. CTG shows the baseline fetal heart rate 110 with the recurrent late deceleration, reduced variability. Bedside ultrasound confirmed the cephalic presentation with the placenta edge located 3 cm from the internal cervical os and incidental retroplacental hematoma measure 80 to 4 cm. 2 large bore IV cannulas inserted, 1 liter crystalloid bolus is given. She remained tachycardic 125, blood pressure 85/65, cross match blood is being repeated. So which one of the following most appropriate next management? Now tell me what is most appropriate next management. Tell me, doctors. What do you think? Okay, why you should go in here with the C-section? What is the reason? Okay, here. Antepartum hemorrhage is defined as vaginal bleeding from 20-week gestation until delivery, right? Our case also 39 week, right? 39 week. Our question, recall. This woman previously had a low line placenta, previously had, which has since resolved at her last biometry scan, 34-week gestation, right? That's what I asked. Like, is it a problematic or not, right? Because it resolved, right? So, despite this, she had presented with the signs consistent with the abruption, the maternal hemodynamical instability, persistent tachycardia, hypertension, despite fluid resuscitation, indicate the significant ongoing hemorrhage. The CTG finding of recurrent late deceleration with reduced variability indicate the fetal compromise too, right? Due to uterine placental insufficiency at 36-week gestation, the fetus is near term and does not benefit from the expected management. Fetal compromise due to present insufficient at 36 week gestation. The fetus is near term and does not benefit from the expectant management. Aim at gaining the fetal maturity. The combination of maternal instability, fetal compromise, and dual placental pathology constitute the OPS emergency requiring the immediate delivery. Proceed to immediate C-section is correct. Why? With the placenta age 3 cm from the internal cervical os, no longer requires C-section. The maternal hemodynamical instability are responsive to the resuscitation and evidence of fetal compromise. That is the indication for this C-section, right? So vaginal delivery is contraindicated due to the risk of further maternal hemorrhage and fetal deterioration, right? Okay, so here administer, then continue CTG and reassess vaginal, no. Continue CTG and vaginal, no. Okay, of not, approximately 90% of placenta identifies low line at 20 week of morphology. Scan will have migrated to a normal position by third trimester. Current Australian guideline recommended a follow-up ultrasound 32 to 36 week for women with low line placenta at 20 weeks, right? So, antepartum hemorrhage with maternal hemodynamic instability or CTG evidence of fatal compromise constitute the ops emergency requiring immediate delivery, usually by C-section, right? So, okay, so we'll go back to our questions. Yeah. Okay, here in our case, female 39, fetal heart sound not heard. Fetal heart sound not heard, 500 milliliter vaginal weight, uterus is firm and tender. The management. Now, what is the management? What do you think? After reading all of that, what do you think in here? What do you think? Okay, here this question actually we need like a. Okay, here we don't know actually the mother vitals are okay or not, right? Okay or not, because like they have not mentioned anything, right? Anything about the vitals and everything, right? Nothing mentioned about vitals, right? So in that case, you have to answer according to the vitals, like yeah, 500. Yes. Okay, here the take the general idea. Here, fatal heart sound not heard. So fatal heart sound not heard mean what? Not heard from what? Fatal heart sound not heard from what? Okay, so can we take this handheld Doppler as an indication of the fatal well-being? What if they have given the CTG monitoring? CTG, like, what do you think about CTG? If they have given us one option as a CTG, what do you think? I'm just asking like the possible things. Mm-hmm. CTG non-reassuring. C-section. CTG is confirmatory. Okay. So we are using ultrasound to what? Ultrasound? We are using ultrasound for what? Ultrasound to understand the baby is dead or not, right? Just okay. Yes, yes, baby is not dead or not, right? Okay. In here, it's depend on the scenario. The moms and everything is okay. Like mom's vitals are okay, right? Then there was a no fetal heart sound present, right? In that case, but mom's is okay, okay. In that case, with the mild vaginal bleeding, in that case, we can think about ultrasound of abdomen, right? Okay, if the mom is deteriorating, mom's blood pressure is dropping, and the mom is having this bleeding, continuous bleeding, uterus firm and tender. In that case, what you need to do? In that case, what you prefer? In that case, what you prefer? Because these questions are depending on the scenario. Ops are always like that. The scenario wise questions, right? We have to understand. Yes. In that case, okay, you can think about the immediate delivery, right? Immediate delivery. Okay, in that case also, okay, yeah, that is another case. Then other case, I'm telling you another other case, okay? Other case is the mom is okay and okay, assume that CTG also there. CTG having sees decelerations and you have noticed the fetal heart sound also uh, not present, and the child is during the labor, okay, child is engaged, mom is fully dilated. In that case, what you can do? Is a C-section or vaginal delivery, what you prefer? Yes, those are the most important things because they are not like there's no theory or anything. Just you have to answer according to the scenario, right? According to the scenario, right? Yes. Okay. Okay, here this is the stepwise approach. Here for this question need more details like a mother's vitals, so like that. But here this we have to recognize the diagnosis. 39-week vaginal bleeding, firm tender uterus is a placenta abruption, right? Assess the mother first, checks airway, breathing, circulation, pulse, blood pressure, oxygen saturation, too large bow, IV can the one that we discussed earlier. Okay, like the start fluid if needed. Then assess the fetalist. Fetal heart sound are not heard, so confirm whether there is a fetal cardiac activity. Bedside Doppler or CTG if possible, right? Ultrasound if viability remain uncertain, right? Uncertain. So in that case, I agree with the ultrasound, right? But depend on the scenario, right? We don't know mom's vitals, okay? If we assume mom is stable and okay, in that case we can go with that, right? Decide the delivery according to the fetal and maternal condition. This is like a general idea, okay? Mother unstable or fetus alive and compromised, urgent delivery, usually C-section if vaginal birth is not imminent. Fetal death confirmed and mother stable, vaginal delivery is preferred, right? If service is suitable, perform amiotomy, then an oxytocin if needed. That is a something else. That is the other case, not in like a very severe case. Okay. It's depend on the scenario. Avoid delay. Do not delay urgent delivery for ultrasound if the mother is unstable or there is a clear fetal compromise, right? So I hope you get the idea. This is the general idea that I can give like overall. Okay. I hope you get the overall idea, right? Is it understandable everything? It's these questions are depend on the mother's vitals, the baby's vitals, and the if it is during the labor, the stage of labor, and the how much is the baby is engaged, and how much is the dilation. Everything matters. Okay, everything matters. You are answering the questions. That's how these obs questions are performing. Okay, so very important, right? Is these things understandable, right? Okay, if we assume mom is stable, then we can go with abdominal ultrasound, right? Right, doctors? You all agree or not? Yes, right. But always think very like deeply this ops question. Like a one word is enough to decide the management. Like a total scenario can change within a one word. Like if a fatal compromise person, the matter, the mom is deteriorating, the mom is the drop in blood pressure, right? So very important, right? That's what most of doctors are telling that the ops are hard. You have to answer according to the exact scenario, how the emergency is working, right? Because these are emergency cases, right? Mom is stable, then in that case you can go with ultrasound. So I hope my explanation is better to understand you, right? To get an idea. Is it all good, right? Yes. Okay, so we'll move to the next question. Hostel security guard, auditory hallucination, feels like someone is monitoring him. Previous history of hostel boys having an amphetamine trial, and security person include the clinical amphetamine trial. What how do you suspect this person is having a psychiatric problem? Previous psychic history, family history, alcohol abuse, stress, and amphetamine trial involvement. So, what do you think? Okay, in this scenario, what do you think? Okay, in this scenario, they are having an amphetamine trial, and security person include the clinical amphetamine trial. They are on something trial, right? Some trial, and like they have not mentioned anything about the previous history or anything. But at this scenario, what do you suspect this person is having psychiatric problem? Why you are suspecting? Why you are suspecting? Okay, what do you know about this amphetamine? Amphetamine. What do you know about this amphetamine? What do you know about this amphetamine? Do you know anything related with this hallucinations? Okay. What do you think? What do you think? What do you know about amphetamine? Amphetamine has a Amphetamine can cause auditory hallucination. Amphetamine can cause specifically auditory hallucination and persecuted illusions as well. Right? Do you have aware about this one? The amphetamines and auditory hallucination. Do you have any idea? Because this seems like they are on amphetamine trial, right? They are on amphetamine trial. Amphetamine trial. Okay, I will show. Let's see. Because amphetamine has a strong association with this auditory hallucination. Here, the amphetamine psychosis, stimulant psychosis, we call. Yeah, signs cause psychotic symptoms, paranoia, hallucinations, delusions. These things can be present. Okay, here, what is amphetamine psychosis? It's a form of stimulant psychosis triggered by heavy or prolonged amphetamine or methamphetamine use leading to the paranoia, hallucination, and delusions. So, what causes it? What causes it? Overstimulation of dopamine and norepinephrine in the brain. So, combination with factors like high dose, binge use, and sleep loss or stress, right? How long? Symptoms often improve with the days to weeks of stopping stimulant use. And then how this is treated. So immediate care focus on the safety, hydration, and calming the agitation with the medications. Long term recovery include the treating stimulants, use disorder with the therapies like CBT or like other management. Okay. Okay. So what is it like properly? Amphetamine psychosis is a set of psychotic symptoms like hallucinations, paranoia, and the delusions that can appear during the heavy or binge use of, and less common during the withdrawal and therapeutic dose of rare cases. Clinical often use stimulant psychosis as the umbrella term because the other stimulant like cocaine, some cations can trigger similar state, right? Okay, in practical, people experiencing amphetamine psychosis are usually depth but profoundly distressed, fearful, and agitated compared with the primary psychosis disorder, right? Okay, so triggers and risk factors we just discussed. Okay, so let's go back to our case. Here again, hostile security guard auditory hallucination feels like someone is monitoring him, right? They have paranoia. They have paranoia and the auditory hallucination, right? You just read it. And previous history of hostel boys having amphetamine trial and security person include in the clinical amphetamine trial. What do you suspect this person is having psychiatric problem? What do you think in this scenario? What do you think? Okay. Yeah, we don't know the trial, the period, like it can be a long trial, right? It can be a long trial. So anyway, they have a exposure, right? Exposure. Right, doctor, they have exposure, right? Was given in this drug. This is like a controversial question. Okay, controversial question. Like in this case, we have two things, right? Anyway, previous psychotic history is like mostly associated. That is the one thing. And that's a very important thing. And in this case, we have two options. We have to think about one and five as well, right? Five as well. We don't know like the trial dose or anyway it's a clinical research thing. There can be a properly managed, right? Properly managed, but either like exposing to this stimulant, there can be like a long term exposing to this trial, there can be hallucination, because the two things they are given, auditory hallucination and paranoia. Here the feels like someone is monitoring him, right? There's some delusions, it's like a persecuted delusion, right? They always like feels like someone is like checking on them, right? Like that. So because of that, we have to think one and two, right? One and just 1 minute. Okay, sorry. I just need to send the link for the our another doctor. I just forget to send the link. Okay. Okay, the Dr. Shampi. Yeah. In that case, think like this way, if they have like given more towards like a as example, they have in a trial, and they are in a trial, and they have like a some misuse as well, right? Misuse, because they are on a trial, and they can do some misuse as well, something with outgoing with the something not properly indicated in the trial, or they have like trial, they have tried more amphetamine, like after trial, the patient, these people can try more amphetamine, something like that, because right, in those kind of case you can think about amphetamine trial. Otherwise this previous psychic history, yeah, can makes more sense, right? So it's depend on the scenario, right, doctor? So that's what I was telling, like in this case, it either can be previous psychic history or amphetamine trial involvement, because the two main thing they have given, the paranoia and the auditory hallucination, these two are very mainly involved with. Wait, what? What do you suspect? Yes, here they are asking the suspect, right? Suspect psychiatric problem, having a psychiatric problem. What do you suspect this person is having a psychiatric problem? It's mostly maybe can be due to the amphetamine trial, right? But okay, what is your opinion? Then I will tell my opinion. Yeah. What do you think? Okay. Okay, what do you think? Yeah. They need to have a prolonged exposure, not just a small trial. So that's it. Okay, if they are like given a proper trial, because if it is a clinical trial, they are like they are properly managing them, right? The dose and the everything, they are trial like properly managing it, right? Properly managing it. In this case, you can go with the previous psychic history, right? Previous psychic history. If it is not like if something related with the misuse or something, in that case, think about this amphetamine, right? That case, you can think about this amphetamine, right? So think according to the question, and here auditory hallucination feels like someone is monitoring him. And the thing is, you need to understand the amphetamine can cause what? The auditory hallucination and the paranoia. That is a very important things, right? But to have this disease, how long? Yeah, usually is binge use of stimulant, right? Binge use or like during heavy or binge use of stimulant. So you need to have the like binge use. Less commonly during the withdrawal or even at the therapeutic dose in rare cases. Here, even at a therapeutic course in a rare cases as well, right? Clinical often use stimulant psychosis is umbrella term. Yeah, it's debate. If a patient is currently and experience symptoms, then maybe, but he says he was in. Mm-hmm. It's like a recent exposure, recent exposure. He was in, right? He was in, not at the moment. He was in, right? Actually, we don't know like how long. The problem in this case, we don't know how long the clinical trial was, right? Clinical trial was during the clinical trial. We don't know like there can be a misuse as well, right? Misuse as well because it's a stimulant, right? Like after using stimulant, some people are getting addicted to it, right? Getting addicted to because they are stimulant, right? Okay, if the question is given here, even like therapeutic dose in the rare cases, but not in all the cases, rare cases. If it is like a long term use, and like something after addiction or something given in the stem, you can go with amphetamine. Or like patient is using stimulant for a long time, like misuse. In that misuse, okay, misuse in that case also you can think about amphetamine, yes, because that is a adverse effect from a amphetamine, like the stimulant induced psychosis, right? If otherwise, like the history can make more sense, right? History can more sense, yeah. Yeah, I also feel like the same way, but depend on the scenario, doctor. In this case, it seems like they have not given anything about it. But yeah, what is it, doctor? The comorbidity. Okay, so let's check. 1 minute. I need to open it. It seems difficult to distinguish substance psychosis from the other psychotic. Wait. I need to share the screen. Okay, what did mention Dr. Sandali? Yeah. Okay, like there should be a prolonged duration, but the problem is we don't know how long, right? So that is the another problem. Induced psychosymptoms, okay, appear quickly and last relatively short time from hours to days until the effect is the drug wear off. Okay, for some hours, psychosis can persist for days, weeks, for months, or longer. It's possible that these people were already at the risk of developing psychotic disorder, which has been triggered by substance use, right? Visual hallucinations are generally more common in substance withdrawal and the intoxication than primary psychotic disorder. This is like overall substance use, right? Yes. But amphetamine is specifically having the auditory hallucination and the paranoia. Okay, that is the most important thing you have to think. Yes, it's a good one. And here you need to have tend to appear quickly, relatively short time. Wait, substance use symptoms tend to appear quickly and relatively short time. Oh, it's depend, right? It can be hours to days until the effect of the drug wear off. Okay, so in this case, like we will take a general idea. If generally they ask in the previous psychic history, make more sense. But here they have not mentioned anything about the previous history, right? Previous history of the security guard, like something related with the some delusions or anything. They have not mentioned. Just only they are trying to highlight amphetamine trial. Maybe they are trying to they are trying to confuse us. Feels like someone monitoring is hosted by heaven. Okay, so for now I will go with the previous psychic history. Okay, previous psychic history because it's the trial, right? The trial is going. What do you? included the previously, right? Okay, so I will go with the answer. Yeah, yeah, even I feel the same way. Okay, we'll go with this previous psychic history. What if it is like a long-term use of this amphetamine, and maybe there can be a misconduct with the amphetamine. Let's see if there's something in the e-medicine. Because that day also I have tried to find, I haven't find anything about it, the amphetamine. No amphetamine, nothing. There's no proper guideline as well, the Australia, for this amphetamine induced psychosis. Postpartum, no, doctor. Acute psychosis not mentioned. Okay, for now I'll mark the previous psychic history, but remember the points that the amphetamine can cause this adverse effect. Okay, amphetamine can cause this adverse effect. That is the one here. These things can be present. Okay, remember paranoia, persecuted delusions, auditory hallucination, agitations, insomnia, amphetamine-induced psychosis. These are very important. Okay, very important. You need to understand about these things. Okay, so yeah, because most of doctors had no idea what amphetamine can cause. Okay, so here, but when you consider with the overall idea, I think better to go with previous history. Next one. Patient comes within 48 hours and have oral ulcers, rash. Scenario seems like varicella or HSV infection. So what you can give valacyclovir, topical acyclovir, reassure. So don't mind this part. Just forget it and give me your opinion. Give your opinion. So what Dr. Grace has shared, what is it? What do you think in here, doctor? What is it, Dr. Grace? I'm just open. Okay. What a stimulant. I'm just reading it, okay? Treatment and harm. Okay, this is for the mm-hmm. Very good, doctors. You remember, right? This question came on June, right? In June recalls. So we'll discuss here. Okay, we'll discuss, yeah. I'll discuss from some questions, then TG. A 22-year-old woman, and I will attach the link Dr. Grace has shared. That's about the amphetamine, right? Amphetamine-induced psychosis. A 22-year-old woman presented to the GP practice with the rash round her mouth, and she noticed the raised bumps yesterday afternoon that slightly itchy and sore to touch. She has no experience similar lesion before. She has no significant medical history and take the combination oral contraceptive pill regularly. On examination, she appears well with vital signs within normal limit. There is a cluster of raised bump on the left corner of her lips and the chin, with some showing small amount of serous fluid oozing from where they have opened. There are no lesions inside the mouth or on the lips. A small tender lymph nodes palpable and the submental region, which she was unaware of. She is scheduled to speak the local community event in 2 days and anxious to know if there is a treatment option to reduce the appearance of the rash. Okay, so keep this scenario in your mind. I'm going to read the options because it's already marked. Because we have done this question on our June recall. So I just copy paste from there. So I'm going to read the options. So here, what type of scenario is here? Okay, here's the options. So oral doxy, Advise that no treatment necessary and will self-resolve. But advise that no treatment necessary and self-resolve. Then oral famiclovir, topical clotrimazole. So what do you think? Oral docs say advise that no treatment necessary and is self-resolving. Oral famiclovir, topical clotrimazole. So what do you think for this scenario? What do you think? It's a very tricky question. Very tricky question. I hope most doctors remember this question because they have done the mistake in that day. Okay, what do you think about this question? Okay, first on oral doxy, second one advice that no treatment necessary and it will self-resolve. Third one oral famiclovir, topical clotrimazole. What about other doctors? Answer, quickly answer. We don't have much time. Okay, why oral famiclovir? Why? The reason? Tell me the reason. Okay, so why? Okay, okay, here. Yes, that is the point, right here. Okay, so the here, okay. So answer is oral famiclovir, and here what they're asking, she is scheduled to speak the local community event in 2 days, and anxious to know if there is a treatment option to reduce the appearance. So here. The clinical presentation clustered papules and vesicles with serous fluid is highly suggestive of HSV. A swab should be collected to confirm the diagnosis, but this should not delay the treatment. Lymphadenopathy and flu-like symptoms may be present in the primary infection. Oral famiclovir is the most appropriate treatment in this case, while the most episode of HSV will self-resolve. This patient has requested the treatment. A single dose of 1,500 milligram is effective against the HSV and can help reduce the duration and the severity, right? Can help reduce the duration and the severity of symptoms when gives early in the course of the infection. The treatment particularly important for this patient to given her upcoming speaking event. The topical acyclovir 5% is alternative option requiring an application 5 times a day for a intra oral lesion. Famiclovir is recommended, while for cutaneous lesion either famiclovir or acyclovir can be used, right? Keep in mind, so advising to keep the area clean and self-resolve, not the most appropriate management for this patient. While HHC lesion will eventually self-resolve, antiviral treatment can significantly reduce the duration of symptoms and the viral shedding, which particularly important. Okay, here it's important to note that while HSV is the most likely diagnosis based on the clinical presentation, and other conditions such as acne, rosacea, impetigo, and the molluscum contagiosum should be considered in the DD differential diagnosis. Acute onset painful nature. Acute onset painful blisters, right? Vesicular appearance of the lesion is strongly support HSV and most likely cause. So prompt treatment with oral antiviral can significantly improve the symptoms, right? Primary herpes simplex virus infection typically present with a clustered vesicle and papules, and the oral famiclovir is a single dose effective treatment for primary herpes simplex virus. Okay, these are the pictures that they have given in e-medicine. So I have attached these pictures only, not the questions. Okay, here can you see this is a typical presentation? Typical presentation. Okay, this is the June recall. Okay, June recall here. Okay, so we'll discuss from here. Presentation and diagnosis of initial episode of oral mucocutaneous herpes. In a neonate, infection with herpes simplex virus can present as isolated skin or mucous membrane lesion, encephalitis or pneumonitis or disseminated infection. 1 minute. 1 minute, doctors. Yeah. And okay, management of complex specialist advice required, that is for neonates. So children and adults, initial episode of oral mucocutaneous herpes is typically more severe than subsequent recurrent episode. For presentation, okay, here the in children, initial oral infection HSV usually present as a herpetic gingivosomatitis, right? I hope you remember the pictures and everything mentioned in the RCH, herpetic gingivosomatitis, that is especially in the children, the initial oral infection. inflammation of the gums and lips. However, some children may not show any symptoms of initial infection. In addition to painful intraoral lesion, signs and symptoms of hepatic gingivitis include fever, irritability, lethargy, and cervical lymphadenopathy. Children may find eating and drinking difficulty, leading to dehydration. Refer children with signs of severe dehydration to the hospital emergency department. Also, refer to the hospital emergency department with the herpes simplex gingivosomatitis. Okay. If you have not remember about the gingivosomatitis, just type in the RCH. Okay, RCH gingivosomatitis. HS. Okay, so in adult, initial oral infection is actually often present as a severe pharyngitis. Herpetic gingivosomatitis is rare in adult, but it can be severe. Adult can be present with dehydration caused by severe odonophagia, painful swelling. So intraoral lesion. HSV begin as a blisters and ulcerate rapidly. Blisters and ulcers usually take 10 to 14 days to heal, right? When assessing a patient with suspected initial episode of intraoral HSV lesion, consider the causes of such as the viruses, right? Varicella zoster, Coxsackie virus, cytomegalovirus, dosing. HSV is the most common viral cause, mouth ulcers, but other viruses also can cause it, right? Then diagnosis is done by what? Mucocutaneous herpes clinically, but the confirmation is required, right? Okay, oral mucocutaneous herpes infection may be initial presentation as undiagnosed HIV infection. So keep these things. I'll show some better things in like a better question. As I've with the pictures. Yeah. Here. Okay, 70-year-old man presented with the 4-day history of itchy rash on face. Many years ago, he had some similar episode that completely resolved spontaneously after 7 to 10 days. His medical history includes the several squamous cell carcinoma removed from his face, hay fever, and celiac disease. His vaccinations are up to date. Examination: the rash is tender, vesicular, and limited to the region of the photograph. Can you, like after seeing this, can you see it as a what? Is it as a what? Okay, so what is the diagnosis? What is the diagnosis in here? Okay, A, B, C, or D, what do you think? Okay, most of doctors are going with D, so let's check. Yes, you are correct. This is what? Herpes labialis, right? So, clinical picture of pruritic vesicle rash around the nasolabial fold on the lips is a typical presentation of herpes simplex, right? This can present with a recurrent vesicles eruption that self-resolve in 7 to 10 days without scarring. Topical acyclovir, whereas cyclovir, famiclovir is usually used for the treatment. So, type 1 HSV commonly associated with the oral and facial infections, where the HSV type 2 commonly associated with the genital herpes. After initial infection, the virus resides the latently and the dorsal root ganglia, and they can reoccur after minor trauma, any immunocompromised and sun exposure or cases, right? So why not herpes zoster? A vesicular eruption is a strictly unilateral dermatomal distribution caused by the varicella zoster, right? So here I'll show the it's like a dermatomal associated rash, right? Like you can see. Here, can you see? It's in the dermatomal, right? Here. So on dermat here. Can you see? It's a dermatomal rash. Right? Dermatomal distribution is present, right? Very important, right? Because otherwise both are like a vesicular rash, right? So remember it's associated in here like this. The dermatomal distribution. Right? So that's what I want to explain other than that. Yes. Okay. Another picture. Okay, here 25-year man, GP, 5 days history of painful sores on the lips. He reported the painful tingling and burning sensation. The typical tingling and burning sensation has a past history of similar episode that used to self-resolve within 1 to 2 weeks, and he has multiple female sexual partners reported that consistently use condoms. As a medical history of SLE, medication include glucocorticoid. Now, on examination, he appears well with pulse rate 88, BP 130 by 85, respiratory rate is 16, temperature 37.1. Inspection revealed the multiple vesicular pustular lesions. Vesicular pustular lesions, which are grouped predominantly over the right side of the mouth on the cutaneous and mucosal lip along the vermilion border, and extended to the left side of the mouth. Right. So here's the one. So what is this? What is most likely diagnosis? Because most of doctors, when they see this picture, they are going with what? They are going with impetigo. So what is it actually? What is it actually? What is it, doctors? Yeah, because I want to show the scenario. Sometimes, if you see this scenario, you feel like this is a impetigo, right? Impetigo. But when you read the scenario, you can understand it's not impetigo, right? So don't confuse this as impetigo, because I have seen many doctors do the mistake, because it's also like a gall crust, right? The honey crust, right? It also seems like that. That's what. Always read the question and see the picture as well, right? Don't jump into you see the seems like something honey crust and not even reading this one, just marking in particular. That is wrong, right? That is wrong. Very important, doctor. So that's what I showed you the question. That day also we have discussed the question and just only attach the pictures only. Okay, I'll attach the pictures as well. Yeah, we'll discuss, okay? And wait. Okay, management. If it is a mild case, mild initial episode, what you can do? Mucocutaneous herpes. The treat immunocompetent patient with a mild initial episode of oral mucocutaneous herpes is a supportive management like hydration, antibiotic drug, analgesic. Oral antiviral is typically not required. So for mild initial episode, oral mucocutaneous herpes of the immunocompetent, apply topical anesthetic or analgesic like benzodiazepine, non-present gel, or benzodiazepine is not available. You can use lidocaine, right? Lidocaine. When using lidocaine viscous solution in infant and children, systemic toxicity and accidental overdose can occur relatively easily. So do not exceed the over the recommended dose, right? If the pharynx is affected in adults and children older than 12, lidocaine viscous solution can be gargled and swallowed, right? To reduce the risk of virus transmission, advise patient to with the active HSV infection and avoid the direct contact of the lesion with other people, right? Other people. A minute. Okay, so management of severe initial episode of oral mucocutaneous herpes. So what are the options? Treat immunocompetent patient with a severe initial episode of oral mucocutaneous herpes with oral antiviral therapy. Few studies compare valacyclovir or famiciclovir with acyclovir for initial episodes of the oral mucocutaneous herpes. However, available evidence suggests that the three drugs are therapeutically equivalent. So remember, three drugs are therapeutically equivalent is the administration and the cost should be considered when choosing the therapy. Treatment is more effective when they start promptly but only reduce the duration of symptoms by 24 hours and does not appear to be diminished recurrences. So for the treatment, we have famiclovir, valacyclovir, and acyclovir. For treatment of severe initial episode, oral mucocutaneous herpes in children younger than 3 months, you have to refer this patient and what you can do acyclovir, right? Acyclovir. This is so immunocompromised. And yes, recurrent oral mucocutaneous herpes. In the recurrent cases, what you can use for immunocompetent patient with a mild recurrent oral mucocutaneous herpes, episode of antiviral may be reduce the duration of the symptoms. Start with the oral acyclovir or famiclovir, right? Acyclovir or famiclovir, but using acyclovir cream for longer than 5 days has no additional benefits. Here, severe recurrence, you can use what oral, famiclovir, valacyclovir, and acyclovir, right? Like that. Here, immunocompetent. This is also immunocompetent. Severe recurrent. Okay, here this is for the infrequent but severe. Here it's a frequent and severe one. Famiclovir, valacyclovir, acyclovir, the same thing. The same thing mentioned in here. Okay, here the cutaneous manifestation, very important, these points as well, okay. The herpetic whitlow, the very important, okay. I will show herpetic whitlow because I'm explaining this. Recently they have not asked because you need to differentiate pompholix from the herpetic whitlow. So what is herpetic whitlow actually? What is herpetic whitlow? This is extra thing, okay. I'm going to explain herpetic whitlow. Do you know about this herpetic whitlow? What is it, Dr. Herpetic Whitlow? Tell me. What is it? Because recently they have not asked Herpetic Whitlow. Okay. Okay, here. Yeah. So, how this happened? How this happened? The Herpetic Whitlow. How it happened? How it happened, doctor? So we were in here. It's a very important thing, okay? Autoinoculation, right? Very important. It's a cutaneous HSV infection of the fingertip resulting from the mucocutaneous inoculation of the virus through the skin break. It can occur in children with oral mucocutaneous herpes who suck their thumb. Very important. And do you know about the Form-Felix, okay? Form-Felix. I remember the exact the word in here. Can you not these pictures actually. I'll show the oh no this one. It also kind of seems like this here. The Pompilix also mostly seems like this herpetic whitlow, kind of different, but you have to differentiate because they are asking these Pompilix from these herpetic whitlow, differentiate in some cases, right? Very important. So we were discussing here, right? Yes. And here, due to the autoinoculation, there's a better picture given in the RCH assays for this herpetic whitlow. Then tender vesicular pustular lesions develop with the localized edema and erythema. And we have here You see, herpetic whitlow, and we have the eczema herpeticum as well. Eczema herpeticum, this also can be asked, very important. It's a widespread herpes simplex virus, complicating pre-exciting skin condition like atopic dermatitis. Right, herpeticum present as an acute widespread eruption of vesicles of multiple crusted erosions. Here, can you see? These are very important thing, very important thing. Okay, don't confuse the things. Yeah. Okay, so we were here. We were did the same thing I discussed from the TG. Okay, so let's go back to our case. Let's go back to our case. So previous come 48 hours and have oral ulcers. The rash, the scenario seems like varicella or HSV. Okay, maybe, yeah, okay, HSV. So given options, what you can do. Can we go with topical acyclovir? Can we go with topical acyclovir? And the treatment should be dependent on the severity, right, doctors? What do you think? But given in three options, not given in three options here, but you can choose. Can we go the topical acyclovir or well cyclovir? What do you think in here? What do you prefer? Just tell me your opinion. That's all I need. What do you think? Okay, here. Read this part also very carefully. So we don't know when to use this one, when to use this topical acyclovir, but this question they have mentioned. Topical acyclovir 5% is the alternative option requiring application 5 times daily for intraoral lesions. Famiclovir is recommended while for cutaneous lesion either famiclovir or acyclovir can be used. Right? And in the TG they have mentioned, TG they have mentioned what? TG they have mentioned the valacyclovir, famiclovir, acyclovir, all of these three has the same effect, right? Those of these three has the same effect. Because of that, we can go with oral valacyclovir, right? Oral valacyclovir. But if it's a mild case, you don't need to go with the this oral antiviral, right? Oral antiviral. But in scenarios, we assume it as a severe case, and we can go with valacyclovir, right? Because here they have given topical acyclovir. If we have a one proper answer like oral drug, I think better to go with that, not go in the alternative one, right? So remember the topical acyclovir is an alternative only. Okay, alternative for this oral drug, right? So look the e-medicine here. They I have highlighted it, right? So you got it right, everything. Please keep in mind, like according to the scenario, right? Here we have got oral acyclovir here. You can give it a rate, okay? You can give it a rate. You can give it a rate, the scenario. Next one. Parent comes with child having a recurrent infection. What to do? IgG level. Don't know what I chose. So, do you remember this question? Don't recall. 18 months old child came with the 6 month history of recurrent chest infection. He has 3 episodes of ear infection, 4 episodes of chest infection requiring antibiotic on examination. His tonsils are enlarged and has a clear rhinorrhea. Weight and height is normal. What is the next step of investigation? Here, what is the next step of investigation? So we have gone with the immunodeficiency, right? Because the recurrent episode of chest and these infections. Okay, I'll show. Yeah, this is the May recall. Okay, so I have went through all the files, all the files, and find it out. So do you remember in May recalls we have discussed about X-links agammaglobulinemia, right? So we'll read this one as well. 20-month-old boy present to the ED with 2-day history of shortness of breath. He has a medical history of 1 episode of acute otitis media in the previous month and 5 episodes of pneumonia in past 7 months. His maternal uncle died from the severe streptococcus pneumonia infection 1 year ago. Has no other significant medical history and take no regular medications. Right, then take no regular medications. On examination, he appears unwell. Pulse rate is 160, BP 90/60, respiratory is 30, red 30, SpO2 94, temperature 38.5, height and weight are both tracking along 50th percentile. Then here Chest examination revealed decreased breath sound in the right upper zone. Abdominal examination normal, or a pharyngeal inspection revealed the absent tonsils, but there is a history of tonsillectomy. There's a no history of tonsillectomy. Chest X-ray showed the well-defined consolidation in the right upper zone. So these are the this is one type of this immune deficiency problem. We call it X-linked A gamma globulinemia. Okay. So because I have attached this thing because these are past recalls and these things can be repeated in July exam. That's what I have attached for the July exam week doctor. So child presented strongly suggests the underlying primary immunodeficiency, especially X-linked A gamma globulinemia. We call it Bruton's A gamma globulinemia. Recurrent bacterial infections in the young male child, family history of severe infection of a maternal aunt, X-linked inheritance pattern, absent tonsil without tonsillectomy, poor development of lymphoid tissues, infections with encapsulated bacteria like streptococcus pneumonia, right? Like that. And we have other in here they have mentioned about the other immune deficient disorders as well. That's what I have attached this question, okay, to get an idea, right? So in this case the recurrent these infections and everything, better to go with I think IG level. It depend on the scenario, but we only got the option as that, right? So what about this IgA deficiency? Is the most common, and the other thing is the IgA deficiency is the most common primary immunodeficiency. Keep in mind, IgA deficiency is the most common primary one. Okay, but it typically present with the milder symptoms and cannot be definitively diagnosed until after 4 age when IgA level reach out this level. The severity of the early onset infection diagnosed until after early onset infection, this case make IgA deficiency less likely. So remember, very important, IgA deficiency, because that is the most common one. And here we don't know the proper scenario, but yeah, we have to go with the Ig level, the immunoglobulin level, to check the patient is having some immunodeficiency or not, right? But remember the X-linked agammaglobulinemia or this Bruton's disease, okay? Bruton's agammaglobulinemia. This came on May. Next one, pregnant lady concerned about diabetes mellitus, BMI 28, mother had preeclampsia. So what you can do, reduce weight or GTT. So what do you think? Yes, and one more thing. Do we have a regular, do we have a regular, like a regular test for checking this diabetes? So, and when is it? The regular checkup? Yes, you don't reduce, so that is out. Yeah, that's a good point, right? You remember that, right? You should not. Okay. Okay. Okay, here. So you are doing as a routine medicine, you are doing OGT at 24 to 28 weeks. 28 weeks for everyone, right? That is a routine thing, right? That is a routine thing. Yes, and here you should remember very important. So you should never do the weight reduction during the pregnancy, right? So here this is prevention of hypoglycemia in pregnancy, including gestational diabetes and subsequent pregnancies. So here this is from TG. So what they have mentioned is increasing prevalence of the obesity. So prevalence of obesity in women is contributing to the increased incidence of hyperglycemia in pregnancy. It can be addressed before pregnancy. So if you want to reduce the weight, it can be addressed before pregnancy. Optimizing women's weight before pregnancy should be strongly encouraged, right? Before pregnancy, losing weight can improve the fertility and maybe reduce the risk of the developing gestational diabetes. However, the rapid weight loss before conception can lead to the rapid weight gain in early pregnancy. Ideally, the woman's weight should be stable before pregnancy and care should be taken in early pregnancy to avoid the rapid weight gain. Very important. At this time of writing, the lifestyle interventions, the dietary intake, and the physical activities during the pregnancy to prevent gestational diabetes have shown a little or no benefit. Keep these things in your mind, okay? Therefore, the focus on the lifestyle interventions before and between pregnancy. The focus is on lifestyle interventions before and between the pregnancies. So bariatric surgery can result in a significant weight loss for women. Okay, I'm going to ask a question. If a woman is done with the bariatric surgery, how long should you wait to get the pregnant? How long should we wait to conceive again? 12 months. Very important. Don't forget this is a recall. Okay, this is a recall. They have asked in April, right? April. 12 months. Never forget it, right? As I remember, it was April. Yes, yes, very important here. Women who have had bariatric surgery should wait 12 months before trying to conceive. Very important. They should take multivitamins and have their blood concentration of iron, vitamin B12, and vitamin D checked. Very important. So that's what they have mentioned about the prevention of the these gestational diabetics during the pregnancy. Okay, not during the actually the before and like what you can do beforehand. So here BMI 28, BMI is increased. Mother had preeclampsia. Mother, okay, not pregnant lady. The mother had preeclampsia, and here, okay, if the mom is in between 24 to 28 weeks, so you can do the OGTT, right? And there are something else we call HbA1c. HbA1c test is doing for whom? HbA1c test doing for whom? For high risk people, right? To high risk people. So who are the high risk? High risk factors for GDM, previous elevated blood glucose level, maternal age equal or more than 40, family history of diabetes mellitus, first degree relative with diabetes over sister with GDM. Do you remember in June exam question they have given sister with GDM? So that is in that case she is a high risk, right? Very important this point. Okay, BMI more than 35. Previous macrosomia like birth weight more than 4.5 kilogram or more than 90th percentile, polycystic ovarian syndrome, and now we are not telling it as a polycystic. Uh, now we are not PMOS, okay, not PCOS. So medications like corticosteroid and antipsychotic use, those are high risk. So moderate risk factors. The ethnicities Asian, Indian, First Nation, Australian, Pacific Islander, the Maorian, Middle East or non-white African. So BMI in 25 to 35. Okay, 25 to 35. These all are like moderate risk. So patient with the risk factors present such as BMI in this patient here 2025 guideline mentioned in first trimester screen for HbA1c test, right? In here also we don't know the trimester and everything. In that case we can't mark any answer for this question, right? We can't mark anything if the patient is between 24 to 28 here. Between 24 to 28 you can go with the OGTT. Otherwise if the patient is in first trimester having these risk factors, you can do the HbA1c. Depend on the scenario, and reduced weight is out. So in this case we can't mark anything because insufficient data in the stem, right? So I'm not marking anything here. I hope you get the overall idea, right? Overall idea. Okay, next question. Hypertrophic pyloric stenosis question. So diagnosis. So hypertrophic pyloric stenosis. What do you know about this pyloric stenosis? So what are the key features that you need to remember in this pyloric stenosis? Tell me, doctors. Yes. So people is having what the patient is having the okay. Let's discuss about the vomiting. It's a recurrent and progressively more forceful or projectile vomiting, right? Projectile vomiting. Or sometimes they are giving it as a forceful vomiting, right? Forceful vomiting. So keep these words in your mind. Then may occur shortly after feeding. Shortly after feeding. That's another key point. Then infant may appear hungry, post vomiting, hungry, present, non-bilious, and blood stain less than 10%. Okay, weight loss, so inadequate weight gain, right? And other than that, the time period is also very important, right? What is the time period? Between 2 and 6 week, between 2 and 6 week of the chronological age progress. Oh, wait, Yeah, it's usually present between 2 and 6 week chronological age. Then passive non-bilious vomiting. It's unlikely after 1 year. Okay, unlikely after 1 year. Here 2 weeks to 6 weeks. 2 weeks to 6 weeks. So remember these things. Okay, definitive treatment by pyloromyotomy. So risk factors: male, firstborn, parents, history of pyloric stenosis, preterm birth, younger maternal age, postnatal exposure of the macrolide, and formula feeding, antenatal smoking during the pregnancy. So these are the risk factors. So examination. So there's a vomiting present, right? You have to make sure about the dehydration. That is another important thing, right? And other than that, you can remember this as a three piece, right? Pyloric stenosis has this projectile vomiting, right? The palpable mass and the peristalsis can be seen, right? So here palpable mass is not in all cases, but you can see the olive shaped located in the right upper quadrant and the lateral edge of the rectus abdominal muscle. Best fell from the left side with the infant settled and supine. May be difficult to palpate, may require a repeated examination or to wait for the several minutes with the hands on abdominal feel, right? But not in all the cases this is visible, right? And other than that, you can see the visible gastric peristalsis. Remember, three piece: peristalsis, projectile vomiting, palpable mass. Okay, and the pyloric mass is can be difficult to appreciate and unlikely to be present in early presentation, right? The management, what you can do. Okay, let's discuss about the yeah. Abdominal ultrasound: 95% of sensitivity in the diagnosis of pyloric stenosis if ongoing clinical suspicious despite the initial equivalent ultrasound. Consider repeat study. So capillary venous blood gas, electrolyte and glucose, because hypokalemic metabolic alkalosis can be present, right? Like that. Treatment: you have to stabilize the patient, gain IV access, you have to assess the severity of the dehydration, right? Then how to rehydrate the patient, stabilize the patient, and what you can do, the definitive treatment is a surgical management, right? Surgical management. Okay. Not the surgical management, pyloromyotomy, right? Pyloromyotomy. So here the diagnosis is stenosis, so you can use ultrasound. Okay. Next one, diagnosis this. Okay, we got this picture. We got this picture. So what you can see once you see this picture, what it can be. What it can be. 1 minute. What it can be, doctors. When you see this question, what is the main thing that yeah, it seems like a keratoacanthoma. Yes, keratin plug, right? Yes, it seems like a keratoacanthoma. So, what is a keratoacanthoma? What type of cancer? What type of cancer is that? What type of cancer is that? Yes, it's a rapid growing squamous cell carcinoma, right? Rapid growing squamous cell carcinoma, right, doctors? Okay. Okay, so we'll discuss about. Okay, what is the management? What is the management? What is the management, doctors? Keratoacanthoma? What do you think? Okay. Okay, here. Can you see, like, this is the picture they have given in TG. Can you see? It's an invasive squamous cell carcinoma, keratoacanthoma, right? Can you see the keratin plug here? Keratin plug. This seems like on the nose, right? This seems like on the nose. Okay, here, can you see this seems like? Okay, we'll discuss. Sorry for that. Okay, here. What do you know about this keratoacanthoma? It's an invasive squamous cell carcinoma. It's the second most common skin cancer in Australia. The tender squamoproliferative indurated lesion, right? Indurated lesion that can appear suddenly and grow rapidly or grow slowly over weeks to months, right? But usually, like the common presentation is the not the slow growing, it's a rapid growing. So very early lesion can be mistaken as solitary lesion of the folliculitis or other inflammatory lesion. Invasive squamous cell carcinoma mainly occurs on a heavily sun-exposed skin like a head, neck, back, hand, limbs, and upper trunk. Right in the photo, the Ricola has given it seems like a nose. Right. A biopsy is recommended to establish the diagnosis of invasive SCC. Right, invasive SCC or keratoacanthoma. Right. Up to 5% of the primary invasive SCC is sun-exposed, right? Sun exposed skin metastasis. The skin metastasis greater of SCC arising from the scalp or ear or lip compared to SCC arising from other cases, right? So, okay, here the treatment and the follow-up. So invasive SCC grow more rapidly than BCC. It should be treated as soon as practical. The treatment of choice is complete surgical excision within 3 to 5 millimeter margin, right? 3 to 5 millimeter margin. 3 to 5 millimeter margin, you have to do the complete excision, right? Complete surgical excision, very important. But remember what you need to complete surgical excision. When I ask what is the treatment, you need to tell complete surgical excision with 3 to 5 millimeter margins. That is the complete answer, right? Because the different cancers has different centimeters, so different millimeters. In that case, you need to remember each and everything. Okay. For a primary invasive SCC where the surgery is contraindicated, advanced age or comorbidities or less like or likely to result in significant morbidity or scarring around eyes or the lips, consider specialist referral for the consideration the radiotherapy. The post-operative adjunct radiotherapy also recommended for SCC have high risk of metastasis, right? Margins are positive, incomplete excision. Histopathology shows the poor adherence of other signs, other high-risk histological subtypes or perineural or lymphovascular invasion. Depth tumor invades in the greater than 4 millimeter. Tumor is more than 2 centimeter in diameter. SCC, the SCC is recurrent and SCC is a high risk site like head, neck, and ear, lip, and ear and the genitals, right? Okay, then the follow-up. After treatment of a primary SCC, follow-up is recommended to identify the local recurrence, metastasis, and the primary skin lesion. The recommended follow-up depends on the patient's risk factors, immunosuppression degree, and the sun damage, the tumor risk factors. And here the review of the patient. Okay, the review of the patient 3 to 6 months after excision for first 2 years, then every 6 months to 12 months. Following up should include the signs of local, regional, and distant metastasis, right? Okay, those are the things you need to understand here. Can you see? It's also emergency picture. Remember, this is a nose picture that emergency has given the nose picture. Maybe the Ricola has tried to remember this question. You never know, right? So this is the nose picture they have given. A squamous, here is a keratoacanthoma. Keratoacanthoma, invasive squamous cell carcinoma of the name. Right here. Yeah, that's all. And here, 1 minute, I put this. Can you see the nose? It's a nose, right? Here, can you see it's on nose. So yeah, that's all for that. Okay, they're asking the diagnosis. So keratoacanthoma. Okay, grief counseling, two questions. One is also the management, and other one also the diagnosis of the grief. Okay, so what do you know about the grief? What do you know about grief? What is grief? Okay, what is grief? Okay, here we'll do this question. 68-year-old woman present to the GP clinic with 3 months after the death of her husband, 45 years. She reports the feeling sad, especially when she think about her husband or sees his belongings around the house. She has difficulty sleeping at night and lost 3 kilograms since her husband's death. She continued to work part-time and the meets with friends weekly. Although she admits she doesn't enjoy these activities much as before, she denies any feelings of worthlessness or suicidal thought. She has a no significant medical history. On examination, appear well groomed but tearful when discussing about her husband. Her vital signs are within normal limit. A score on this PHQ is 9. So, which one of the following most likely diagnosis? Okay, so it's a normal grief, right? So, why? The patient presentation is consistent with the normal grief. Grief is normal response to the loss, and while it can share symptoms with the depression. Okay, so there are key different things. So we have the normal grief, and what is other grief? Other grief is complex grief or complicated grief, right? So I'll explain that one as well, okay? So in this case, the persistent sadness is specifically related to the thoughts of her deceased husband, which is characteristic of grief. And she continued to function in her daily life, maintaining her job and social connection, and albeit with the reduced enjoyment. Importantly, she denies feeling of worthlessness of suicidal thoughts, which are more commonly associated with the major depression. Right? Okay, then what else? Okay, what is persistent complex bereavement disorder? Characteristic by intense longing for the deceased or preoccupied with the circumstances of the death and the significant functional impairment persisting for at least 12 months after the loss. While the patient is experiencing grief, her symptoms do not appear to be severely impaired in her functioning and has only been 3 months since her loss. Right? Okay, here. Okay, it's important to note that grief can be long process and symptoms can be persistent for months or even years. However, the most people experiencing normal grief do not require medical interventions unless the symptoms worsen persistent to the point of the significantly impaired in their daily functioning. Regular follow-up and support are important to monitor for the development of the complicated grief for major depression. Okay, the normal grief can persist with symptoms similar to depression, but typically characteristic by vagueness of sadness and thought of disease, right? Persistent feeling, worthlessness, anhedonia, suicidal ideation are more indicative of this major depression, right? The duration and symptoms as well as the impact of the daily life help to differentiate depression from this grief, right? Okay. Mm, okay, that's it. 1 minute I'll show. Okay, the other one, the complicated grief or the prolonged grief. So you need to know this one as well, the normal grief, and we have the prolonged grief. So prolonged grief disorder, the complicated grief arises when the grief cannot be integrated, resulting in persistent and severe emotional distress that impairs the functioning of the most days for at least 12 months after the death. Very important, okay? So here, uh, what they have what preoccupation with disease, the intense hearing of the disease, feeling purposeless and futility, numbness of the detachment, distress in intrusive images or memory about death often related to the circumstances of the death, right? So excessive guilt, remorse, and self-approach, especially relating to the events surrounding the death or disease, sense of life being empty or meaningless without the disease, the excessive irritability, bitterness, or anger, right? Very important. Here, if the prolonged grief disorder suspected, further assessment of the management required. The prolonged grief disorder or grief questionnaire may be with the diagnosis. Consider special referral bereavement interventions such as specialist bereavement counselors, palliative cares, right? Those things. Then tell me here, separation distress can be present, intense sadness, tearfulness, and the loss of usual activity and the undertaken normal tasks, withdrawn from others, physical symptoms including fatigue and loss of appetite, sleep disturbances, anxiety about the future, right? Those things are the main important things. So I hope you differentiate, you get the idea about the complicated one and the normal grief. And then I'll show about the this thing. Yeah, here, this is a 67-year-old woman present to the son to the GP. 4 weeks history of difficulty falling asleep, tossing and turning the approximately 2 hours before falling asleep. She reported the sleeping for only 4 to 5 hours at night, and the blames on her body clock waking at early 5 a.m. Her husband died the cardiac arrest 6 weeks ago, with her sleep issues starting 2 weeks after his death. And son report that he hears some mother weeping silently in her bedroom. He stated that she occasionally hears her husband's voice at the night, right? Transient hallucinations you can see, and then appears in her dreams nearly every day. And she feel 1 minute. Okay, here, she like reminiscing the good time spent with him. Those memories are the only things keep me sane. She seemed defensive when asking about the feeling depressed or self harm. Right, so she lost 4 kilograms over the past month and not cooking as much as for herself and the grandchildren. She has also stopped the attending to the weekly society and gathering her friends, but still able to perform her activity, right? 1 minute. Sorry for that. Here they are asking which one of the following is most likely diagnosed. So normal bereavement and the grief. So what is it? Normal bereavement and the grief is occurs that happen after individual experience a tragic event like this death or the separation like that. And the normal bereavement usually experience the pangs of the grief association with the thoughts or reminder disease that can occur very sporadically. Similar to the patient, emptiness and those things can be present. Like you can give it a read, right? So, and mild hallucinations such as hearing voice of the disease and visions of the dreams decrease are all normal occurrence. Grieves individuals, right? She should be more confused with the psychotic disorder and loss of appetite and associated weight loss in common symptoms in normal bereavement and grief. Now tell me the management of the management. Now tell me the management, doctors. So how you should manage this grief patient? Grief patient, how you should manage? How you should manage? Yes. Okay, so what include this bereavement council? What this include this bereavement council? What is this bereavement council? What include it? So here bereavement therapy. So it includes empathy and consolation, right? I'm sorry for your loss. So in the there's a one question in the old handbook question. Okay, handbook question they are given a scenario about this grief and they are asking the management. In the one answer was like comfort and console, something with consoling. Okay, the other answer is defibrine. So in that case, what do you go with that? Like initial management, console or defibrine? What do you think? What do you think, doctors? What do you need to do? Initial management, consoling or debriefing? I'm just asking a question because, like, sometimes the handbook questions are repeating because there was some difference. Okay, if you see a question, okay, what does mean the defibrine? Defibrine, what is defibrine? What is defibrine? Defibrine is like a creating a safe space to open up for them, right? Like we are making a Yes, we are making a space that person to open up, right? Because they are after loss or separation or something like they're grieving, right? So in that case, yeah. But initially, okay, when a patient is come, what you need to know, what first you need to console and the comfort the patient, right? Like, I'm sorry for your loss, right? Like, you have to comfort them and the console, then you have to defree right? Then you have to console them, then comfort them, then you can make a safe space them to open up and tell about their scenario and everything, okay, like that. Yeah, I hope you get the idea. 1 minute. Yeah, sorry for that, right? So keep this point in your mind so you don't know the question. Okay, next one. 70-year-old back pain tries to close window. He got vertebral fracture, calcium plus 2, parathyroid hormone increase. Then the only option we got as parathyroid adenoma. What do you think? So what is the problem here? What is happening? Calcium increase, hypercalcemia, parathyroid hormone increase. So what is this? Diagnose this. Diagnosis, doctors. What is this? Diagnose. Yes, why primary hyperparathyroidism? So there's a hypercalcemia, right? Hypercalcemia present at the same time parathyroid hormone also increase, right? So parathyroid adenoma, right? Primary hyperparathyroidism, right? Okay, I'll explain about this hypercalcemia. So first of all, tell me about the normal calcium regulation in our body done by what? This parathyroid hormone and vitamin D and bone turnover, right? So how they are doing increase the calcium resorption from the kidney. This parathyroid hormone, the functions increase calcium resorption from the kidney, increase bone resorption, increase vitamin D activation, then increase the gut calcium absorption. Right, all together there is the serum calcium. Right. So pathophysiology of hypercalcemia. So what is happening in hypercalcium? This is a normal pathophysiology. So if it is a problem in one of these pathway, then they can increase the hypercalcemia. Okay, increase bone resorption, increase intestinal absorption, reduction of renal excretion. Right. So these things can be a problematic, right? Then can cause this hypercalcemia because they are releasing this calcium to the blood, right? Okay, here. So then you have to think about the causes and mechanism. Specifically, the most common cause is the primary hyperparathyroidism. So what is primary hyperparathyroidism? So in primary hyperparathyroidism, the cause is what? Parathyroid adenoma. Very important, okay? So excess parathyroid hormone, if there's adenoma in parathyroid gland, this adenoma can increase the parathyroid hormone. This parathyroid hormone can increase osteoclast activity, then bone breakdown, increase the renal calcium reabsorption, then increase vitamin D activation, then result in chronic to mild to moderate hypercalcemia. Hypercalcemia, right? Hypercalcemia. So in this case, parathyroid hormone high or inappropriately normal. That means inappropriately normal. Very important. Okay, these points. Right, doctors here? Primary hyperparathyroidism is the mostly common cause. The single parathyroid adenoma. Definitive therapy is surgery, which cures. Okay, I'll explain about this treatment later. Then we have other mechanism. Malignancy related hypercalcemia. So if the patient is having the malignancy, there can be malignancy related hypercalcemia. There are also two mechanism you have. There are also two mechanism you have. So what are those things? Like if the cancers in the breast cancer, so this lung cancers, they can reduce some peptides that are acting like that are acting like this parathyroid hormone. We call them parathyroid related peptide. Not the parathyroid hormone, but it's like a peptide related parathyroid hormone, right? But the function is the same as parathyroid hormone, and they are cause some cancers secrete this parathyroid related peptide acts like a parathyroid hormone, and calcium is rises, right? Calcium rise, especially you can see the lung and breast cancer, right? Then other mechanism is what the bone metastasis, right? If the tumor invade the bone, then direct osteolysis can be present, right? So calcium release into the blood, right? Seen in breast cancer, multiple myeloma, like that. Then other cases are vitamin D excess, right? Reduced renal excretion, and those things. And these are the causes. Other things: vitamin D excess, A excess, immobilization, thyrotoxicosis, those things. Okay. And the next step, what you need to know. So these are the causes. Then you need to understand this hypercalcemia, parathyroid hormone, dependent or independent. What does that mean? You have to understand this hypercalcemia is due to parathyroid hormone or not, right? If it is due to parathyroid hormone is elevated or inappropriately normal, and the most common cause is the primary hyperparathyroidism. There can be tertiary hyperparathyroidism as well, but most common one is primary hyperparathyroidism, right? If it is parathyroid independent, that means there's a no connection with the parathyroid hormone, but with other mechanism, they are increasing the calcium level in the blood. Vitamin D, mobilization, the sarcoidosis, neoplastic related disease, milk alkali syndrome, adrenal insufficiency, thyrotoxic, like this. Okay. Then, what are the clinical symptoms? What are the clinical symptoms you have? We remember it as a stones, bones, groans, and psychic overtones, right? So, renal stones, bone pain, constipation, abdominal pain, polyuria, these things can be. So then most important is stepwise investigation. Confirm hypercalcemia, how to collect calcium ionized calcium. Then you have to check the parathyroid hormone level. Why? Because you have parathyroid dependent causes and parathyroid hormone independent causes, right? In that case, you have to check parathyroid hormone. So this is the most important next step, right? Because if the parathyroid hormone is high or inappropriately normal, inappropriately normal, then it's a primary hyperparathyroidism. You have understand the primary hyperparathyroidism, you can easily do the imaging and find out there is a cancer, there is adenoma or not, right? Then if it is the parathyroid hormone low, you can think about malignancy, vitamin D excess, so these granulomatous other disorders, right? Then you have to do the vitamin D level, the myeloma screen, those things, right? I hope you get the idea, the overall idea. Then let's go with this one. Yeah, go with. Okay, what you can do is there is a primary hyperparathyroidism. What you can do. Here, if it is a primary hyperparathyroidism, it's commonly caused by a single parathyroid adenoma. Definitive therapy is surgery, which cures 95% of cases and has low morbidity. Right, so watch and wait approach can be considered instead of the surgery in patient over who are 50 years or old. Remember this point, very important, because not all the adenomas are going with the surgery. Okay, if it is patient who are 50 with these things, total serum calcium concentration corrected for albumin lower than 2.9, normal kidney function, no nephrolithiasis or nephrocalcinosis, a bone mineral density is higher than -2.5, or no symptoms. If these things are present, can go with the watch and wait, right? Watch and wait, right? So I hope you get the idea. In here it seems like calcium and parathyroid increase seems like parathyroid adenoma. So then why this is what about this vertebral fracture? Now tell me about this vertebral fracture. What do you think in this case, doctors? Like, what is the thing that you can think about in this case? And what are the doctors? Because you only got parathyroid adenoma. Okay, what about other doctors? Quickly tell me, like, your opinion. Yeah, it can be minimal trauma fracture, right? It can be minimal trauma fracture. He is a 70 years old, right? 70 years old, right? Yeah, it can be minimal trauma fractures, right? Minimal trauma fractures. Right, doctors? Minimal trauma fractures. Right? But here, like the main problem is what? Main problem is parathyroid adenoma, right? What do you think? Do you have any other idea? Because if it is something else, like some as a multiple myeloma, something else, this parathyroid hormone should be not increase, right? Not increase, right, doctors? It should not increase. The main most important point is what? The parathyroid hormone increase, right? Right? Right, doctors? So like maybe this answer is the better one, right? Better one. This can be this the like this one, the fragility fracture, right? Because of the old, right? Old age in here. 70 year, the back pain, vertebral fracture after minimal trauma, the close-in window. So very minimal trauma, right? Fragility fracture. Calcium ion elevated, the parathyroid hormone elevated. Seems like a parathyroid adenoma. Most probably this can be the answer. I remember, I think there was a one question related to the multiple myeloma as well, but I can't remember the exact date. Okay, but we will find it out once we are doing it. I hope you get the idea about the generally about this hyperparat. Sorry, that, sorry, this hypercalcemia topic, right? Hypercalcemia topic. Okay. Next question. Next question. 12-week pregnant female came with the vaginal mild bleeding, cervical osseous close. What will you do next? CTG, ultrasound, TVS. What do you think? Okay, what do you think, doctors? Mm-hmm. Yes. So, do you remember the June record? Female with irregular periods, last menstrual was 7 weeks ago, is CG positive. Mild vaginal bleeding, no abdominal pain. How to assess the fetal viability, right? So, you had to do what? TVS, right? Why you need to do TVS? So it's depend on the TVS. It's depend on the vaginal ultrasound, right? According to that only we can decide is it what type of miscarriage is this, right? I doctor because otherwise we can't tell. That's why we are doing the TVS, right? To get the idea as a sac present, right? Like that. Yes, you had to exclude. Okay, I'll explain here. On transvaginal ultrasound, gestational sac will usually be visible from 4 weeks and 3 days after the last menstrual period, right? Assuming the dates are correct and the menstrual cycle is regular. So, a non-viable pregnancy is diagnosed on ultrasound under either or both of the following circumstances. No live fetus visible in the gestational sac where the mean sac diameter is more than 25 millimeter and the visible fetal pole with the crown rump length is more than 7 millimeter with no fetal heart activity after period of observation and at least of 30 seconds. These 2 points are very important because they have asked in e-medicine. Very important, okay? Very important. Yeah, very, very much important, okay? Yeah, here the non-viable pregnancy diagnosed on ultrasound following circumstances. Very important. Here, this is the transvaginal ultrasound. It's the preferred first trimester ultrasound, right? As is the pregnancy location, intrauterine was ectopic, then fetal viability, fetal cardiac activity, right? Viable or not, right? If viability is uncertain, then you had repeated it 1 week and obtain second opinion. If no intrauterine pregnancy is seen as the ectopic pregnancy and the consider pregnancy of unknown location, right? It's depend on the scenario. I depend on the scenario, but here they are asking what you can do next. Next is TVS. According to TVS finding only, you can decide what is going on, right? What is going on. Okay. I remember these points, yeah, and I have attached like how these miscarriages are present. We will discuss once we get the question. In July, the threatened miscarriage and the missed miscarriage has repeated like a lot. A lot questions are repeated in July. Okay, so we'll do this one. Female present in her second trimester with bleeding. 3 previous deliveries were normal and uneventful. What will you investigate? Folic acid, ferritin, iron total serum. What do you think? Type your answers, doctors. Why ferritin? What is the importance of checking ferritin? Tell me. What is the importance of checking ferritin? Tell me, doctors. Okay. Anemia and pregnancy. Okay, this is a RHGP guideline. I got this chart from there. Okay, here. So, uh, a female present in second trimester with bleeding. 3 previous deliveries were normal and uneventful. So keep in mind. Okay, keep in mind. Then, delivery were normal and what will you investigate? So in this given options, most probably they will give low HB, right? They will give low HB or normal or trend in low HB because that is that point we need. That point we need to think about next step, otherwise we can't think about next step, right? So that is the most important thing, right? They have not given, but maybe they should give. Okay, in the exam they will give. So here low HB or normal or trend in low HB. So then you have to check what low MCV. You have to check the MCV, right? So according to the MCV, you are categorized, right? You are categorized things. Here, if it is low MCV, then you have to think about the RCC, right? If it is normal MCV and RCC normal, then you have to think about the ferritin. Okay, just remember the first hemoglobin, then MCV, then RCC, then the next step is a ferritin, right? Ferritin. So stepwise, remember. Okay, we'll go with this side. Low MCV, RCC normal. Oh, here RCC increase. So if the RCC normal, you have to then check the ferritin, right? If the ferritin is lower, then you can think about the iron deficiency anemia. If it is normal ferritin, you can think about anemia of chronic disease, right? Then, if you check the RCC, RCC is increased with low MCV and low HP, then you have to check the ferritin. If the ferritin also increase, decrease or normal, then you have to think about the thalassemia, right? Thalassemia. It depends on the RCC, right? So here RCC normal and ferritin is less than iron deficiency again here in normal MCV. In normal or increased MCV, normal or increased MCV, then RCC is normal, the ferritin low or normal, then consider vitamin B12 deficiency, right? So this is the way of you should investigate. I think, yeah, this is okay. This is the system wise. This here, like a fully they have diagnosed anemia. Here they have not. No, he also not mentioned about the patient is anemic. Here, according to the trimester, they already diagnosed it's anemia. Yeah, anemia less than 70 to 80 HB. You have to check the ferritin. If ferritin is less than 30, you have to, here's the management, commence oral iron. So ferritin is more than 30, then you have to consider the cause of other anemias and hematological referral. Right, if after the commencing oral iron also, we have to do the hematological reference and consider IVN third trimester. Yeah, anemia should be less than 110 or less than 105 second trimester. Here still less than 30 you can give oral iron. More than 30 consider other causes like the it depend on the scenario. Okay. Yeah, okay. Right, doctor. So in this case, we are assuming this is they have already checked MCV and the HP. In that case, to diagnose the iron deficiency anemia. So, or like if it can be another disease like a thalassemia, and then you have to check the next thing. Main most important thing is ferritin in given options, right? In given option, but don't worry, in the exam you will get the proper question. Right, so that's the only thing I can tell. You can get the proper question right here because they have not mentioned anything about full blood count or anything, but you can you can check the iron store right from the serum ferritin, and then you can think about it, right? If the low ferritin, mainly you can think about the iron deficiency, right? Serum, like that. Okay, so I remember we got a better question later, okay? So get the idea. And here remember the iron deficiency anemia having for approximately 50% of cases worldwide in the pregnancy, the anemia 50% from this iron deficiency anemia. However, few studies have determined the rates of IT in Australia pregnant population like that. Okay, so you don't need to read. Next one, graph which point show the 100% specificity. 100% specificity. Which point? 100% specificity. Okay, how you should remember these things? So, you are in front of the computer, right? Or laptop or whatever you are using. Take your right hand. Like you always, you are using right hand, right? Your dominant hand is right, right? I'm not talking about the left-handed people, okay. Your dominant hand is right, so right hand is always specific, right? So specific is right hand, and once you see your right hand and this chart is specificity in the right hand, so remember your right hand is specific hand, right? Specific hand. So here the specificity, other side is the sensitivity, right? So if you are not like if you can't easily remember this, remember like that your right hand is specific hand. If you are going to the right side, it's a specificity. So they are asking 100% is specificity. So it is what here 100% is C, right? 100% is specificity is C. So specificity like that. Okay, then. Okay, if they ask B, what is B? Is a most accurate point. Remember this point also they can ask. Okay, most accurate. And here the A point is what 100% sensitivity, right? Sensitivity. The crossing area is the this one is the most accurate point, right? Most accurate point. Okay. Child hearing voice to kill his classmate. Next best step. Inform police, inform kid, inform parents of kid, inform school principal. So what you can do here? What you can do here, doctors? Okay, tell me your opinion quickly, quickly. It's almost more than 4 hours. Tell me your opinion. What about other doctors? Inform school principal. Okay. Why school principal? Okay, I'm asking a question. Do we need to inform the parent or carer? Okay. Okay, tell me stepwise what do you think? Stepwise approach is what? What do you think? Okay. Then? Then what? Then what? Then inform school. Okay. So in here, they will enroll parent and police. Okay. So here they are telling, here we have to answer as who? Child hearing voice to kill his classmate next best day. Okay, child is at the moment in where? You are the doctor. Child is in where? Okay, at the moment your child is where? In the hospital, right? In the hospital, right? Because otherwise, how? Like you are a teacher or you are a principal? No, right? Child hearing voice to kill his classmate. Because you are working as a doctor, right? So you are with this child, not in the school, right? Tell me, doctors, you are not in the school, right? Or not? You are thinking this is a school scenario, or what? Because that is more important. Yes, okay. So you are the children and you are in the hospital, okay, hospital, and you are assessing this child, and are you as informing the child is telling hearing voices and kill classmate during your assessment. The child is telling. Doctor, just give me 1 minute. Sorry for that, doctor. I got a urgent call. Yeah, okay. So what we were discussing. So you are assessing the child and you are telling that in that moment. So you are informing a school principal. Okay, you are in with the child, and the child is telling this, and you are just inform the parent or the inform principal at the moment. Tell me, what is better? Yes, because this is not the school, right? This is you are like it's a patient, right? He's a yeah parent, right? Okay, this is the stepwise approach. Assess the immediate risk, right? First of all, anyway, the safety first, immediate risk, right? Then you have to inform the parent and the guardian, right? Then you can arrange the urgent child and adolescent mental health assessment because you need to do the mental health assessment, right? If there's immediate serious threat that cannot otherwise be managed, then confidently maybe breach to protect others, including involve the security if necessary. Okay. As example, the child is hearing voice and kill the classmate, and he's very aggressive at the moment. Aggressive at the moment, he was like, "I'm going to kill them after this." After this consultation, in that case, that is the safety problem, right? In that case, you have to like the secure the child. Maybe you can do the involuntary involuntary admission, right? In that case, the security should be always first. But in here, they are not like telling that, just child is telling to you, right? So these voices and these things are happening and telling that. In that case, a better option is you can inform the parent first, right? But always assess the immediate risk, right? There can be risk for the staff as well, right? It's staff as well, because it's like the voices are telling to kill someone, right? Kill his classmate. So assess the immediate risk. That is the most important. They inform the guardian or parent or carers. Then you can arrange the assessment, mental health assessment, right? If you need, you can take the security action as well. It's different in different scenario, not for in this case. Okay. So this is how you should assess. So let's think you are assessing a patient in a hospital setting, no GP setting, no whatever, like not in the school, right? Not in the school here. If they want to give a scenario like you are visiting doctors in a school, then you find out like it can be different, right? In that case, you can think about the inform school principal, and the principal can inform the parents. That can be different, but this is not the scenario. Okay, always think very carefully, and this is like a very little amount of the recall, so there can be better scenario, then you can anyway get the answers in from parent of a kid. Okay. Okay. Okay, so yeah, what's the time? Yeah, doctor, we'll stop from here. We'll stop from here and we'll finish this file tomorrow. So we have done the 75 page, right? So yeah, again, we have to done like more pages, but it's fine. Tomorrow we'll do, because I have to do the other session as well in 6, the free session. And yeah, then I have my dental appointment after that. I have to do the 2 surgeries for both side of my the molars, and I have to open the bone and remove them. Then I have another tooth for the nerve filling as well. Yeah, I hate these dental problems. Yeah, doctor. Now there's no pain actually, because everything is temporary filled and everything is okay. But the definitive treatment, the temporary everything is settled. The definitive treatment should be remove those the other teeth, because there's a no space for them to come out. They were like just growing, but not coming outside. There's a no space, so the X-ray shows the better opinion. I got 3 dental surgeons' opinion. So yeah, the only option I have the surgery. Yeah. It's fine, doctor. So anyway, I have to face it before going to the Melbourne. Otherwise, it will cost me a kidney, right? In Australia. So that's what I have to do it in here. Okay, okay. Just for fun. Okay, so we'll meet tomorrow, doctors. Okay, have a good day. I will share the recording once it finished, convert into the my laptop. Yeah, so and I will upload within 1 hour. Okay, this PDF as well. Okay, doctors, have a good day. Bye bye.